Yeah, well, welcome everybody, and thank you so much for calling in. This is Bruce Robinson at Arbor Research Collaborative for Health, and we're pleased to this afternoon provide latest emerging trends webinar from the DOPPS Practice Monitor. Again, thank you so much for joining us. Okay, so I will give a brief introduction and a quick summary of the U.S. trends in in-center hemodialysis over the last several years. But actually, the bulk of today's session we have devoted to an exploration of differences in dialysis practice between the U.S. and Canada. And Professor Minish Sood will lead that presentation. Mark Newman will speak towards the end of the hour on U.S. policy updates. There remain and continue to be a lot of important updates in the dialysis space. Next slide, please. All right, just our acknowledgement slide. Thank you again to our sponsors for support for the DOPPS and the DOPPS Practice Monitor without restriction on our publications or presentations. All right, and I'm showing here just a screenshot of the DOPPS Practice Monitor, publicly available at the website as noted. The DOPPS Practice Monitor has over 1,000 figures with data tables underlying those, providing most recent trends in U.S. dialysis practice based on our national sample of over 200 dialysis facilities. Our April update provides data through February of 2017, so just a few months lagged. In addition, just so folks are aware, we now have a DOPPS Practice Monitor for Canada, Germany, and the Gulf Cooperation Council countries, which are the countries of Saudi Arabia and other countries in the Middle East as well. And for those interested, you can actually toggle from this web page to any of those four countries or groups of countries. And in particular, with the Canadian DOPPS Practice Monitor, this is one reason that we've asked Dr. Sood to join us and discuss findings that emanate from comparison of the U.S. DOPPS Practice Monitor to the Canadian site. Next slide, please. All right, just a reminder, please join us for conversation on Twitter. You can follow us at DOPPS Study and use the handle DOPPS for tweets about today's webinar. Great, okay, thank you. Next slide. And CNE credits are available for this web conference. We have information as noted on this slide. These slides will also be available immediately following the session today for those who want to refer back to them. But again, we give thanks to Nephrology Clinical Solutions for providing continuing education coverage and credits. And indeed, for our Canadian audience, Canadian College of Family Physicians, or CFPC, will accept the NCS CNE certificate. So this process can be used to obtain continuing education credits in Canada as well. All right, learning objectives as listed, which I think I can skip through. Okay. And as always, we're very interested in an interactive session, so we'd be happy to have folks submit questions and leading to discussion and response here. You can actually submit your questions electronically using the Chat with Presenter feature, which is accessed by the blue icon located at the bottom left corner of your screen. And we'll pause at the end of each section to address questions as they come up. And as well, we have an interactive polling feature that we've used for the last several of our DOPPS Practice Monitor updates. We'll actually be asking questions principally related to treatment practices at your unit, as well as some other content that you'll note. When the poll is open and displays on your screen, please answer the question and don't forget to hit the submit button. So we'll have questions that arise over the course of the hour. All right. Now, I actually just have two slides summarizing some of the more recent trends in U.S. in-center hemodialysis practice. Okay, first of all, with respect to dialysis prescription practices, I'm referring here to for example, KG/V treatment time. There have been no substantial changes over the last several years. So, of course, very high proportion of patients achieve KG/V above the minimum requisite of 1.2. At the same time, treatment time or dialysis session length remain relatively short in the U.S., as Dr. Sood will comment on a bit later. A brief summary of trends in anemia include, first of all, hemoglobin levels have held steady at around 10.8 grams per deciliter. And that is despite some changes in movement from short-acting epoetin alpha to Mircera, which is pegylated erythropoietin beta, which use has risen up to 35%. So now 35% of patients in the U.S. Are using Mircera, and another 18% are using darbepoetin as well. The median dose of EPO, including doses converted to short-acting epoetin equivalents, is generally steady and has been steady for several years, around 8,000 units per week. Use of subcutaneous ESA was quite high among our non-LDO sample at 40% a couple years ago. This has actually declined substantially down to 11% more recently. And the LDO patients are not using, to speak of, not using much sub-Q EPO. So nearly all at this point is being dosed by IV. Lastly, ferritin levels remain very high in the U.S. with a median of 789 nanograms per ml. Dr. Sood will actually show a graphic related to that a bit later. And the second U.S. dialysis trend summary slide, with respect to mineral bone disorder, we've reported for several years that PTH levels have generally risen over the last, well, let's say 5 years or so, with a median value now of 373 picograms per ml, and a high proportion of patients above 600, as Dr. Sood will comment on a bit later. There has been a substitution over the last year, or last 1 to 2 years, of oral calcitriol, which is now being used much more commonly than it had been before, in lieu of IV active vitamin D, or in addition to IV active vitamin D. Again, the contrast to what's gone on over years in Canada will be of interest, and we'll get to that in a moment. There's been a possible rise in cinacalcet use, now up to around 30% of U.S. dialysis patients. And lastly, good news is that use of centrovenous catheters for dialysis continues to decline in the U.S., now down to around 13% of prevalent dialysis patients. So that's excellent news. Next slide, please. All right, now then, moving on to the sort of core content of today's discussion. Just before getting there, before introducing Dr. Sood, I was just going to note that within the DOPPS over the years, we have focused on understanding variation in dialysis practices within countries and across countries, and ultimately helping leverage those differences to understand optimal care and identify optimal care for patients. And some of the differences in care that we'll see today, we understand may have clear impact on outcomes. In other cases, it's a bit less certain, but in all cases, actually, certainly of interest. And as far as I'm concerned, I mean, what we see here is differences in healthcare systems, in this case between the U.S. and Canada, that are helping drive substantial difference. And these differences may be due to differences in reimbursement, differences in quality measures, differences, less easy to measure differences, perhaps just in the culture of dialysis care in the unit, or basically physician preferences as well, that may arise somewhat organically, but ultimately lead to quite substantial differences in care. And again, with the effect on outcomes that is of real interest to us and merits additional research. With that said, I wanted to pass the microphone over to Manish Sood. Dr. Sood is a assistant professor of medicine at the University of Ottawa, and he's also a scientist with the Institute for Clinical Evaluative Science at the University of Ottawa. Dr. Sood also joined as a DOPPS country investigator within the last year or so, along with Rita Suri, who's at the University of Montreal. And both Rita and Manish are taking over from really a long tradition of success with the DOPPS in Canada. The DOPPS in Canada has been going on for over 15 years. A lot of important, led by David Mendelsohn and Jean Etier for many, many years. And there's been substantial research output from the DOPPS Canada group and a lot of interest in their data over the years, both the Canadian data but also comparisons internationally. So we're really grateful for the dedication over the years of our DOPPS investigators and country investigators in Canada, and in particular to Manish and Rita for your leadership taking over in recent years. One other name to mention is Dr. Jeff Pearl, who along with Rita and Manish leads the DOPPS program in Canada. Jeff focuses in particular on the peritoneal dialysis study in Canada as well. So with that said, I'll pass the microphone over to Manish. Next slide, please.
Well, thank you very much, Bruce. Thanks for the introduction, and thanks for everyone for being able to take time out of your day to join us on this call. Just before we start, I'm going to add a little caveat to what Bruce said, a little precursor about what we're seeing and discussing. As mentioned, we're going to, Canada and U.S. are so close geographically, but what you'll see as we go along is in some ways, in our dialysis practice, we are worlds apart. And I think it's fascinating to see these differences, to realize that there's many ways to perhaps reach a similar management strategy or endpoint. But it's very difficult to make the connection to outcomes based on these patterns. And I think it's a difficult leap to make, and that area of the research is still active and pending. The second point right before we begin is just I think the other interesting part of this exercise is it really illustrates how well the Dialysis Practice Monitor can be used to compare perhaps your facility to national statistics, so and also inter-country comparisons. So it allows for comparisons at least with similar data fields and characteristics between countries, and I hope we can illustrate that today. So a brief outline of what I'm going to discuss. Very briefly, I'm going to go over some key differences in our healthcare systems and perhaps how they pertain to the ESKD population. We'll go into incidence, modality types, and outcomes. We'll describe the demographics of the dialysis populations between the two countries. We'll talk about dose and prescription. And then we're going to focus a lot on therapeutics and do mineral and bone disorders, anemia and iron. And lastly, we'll touch on the vascular access. And next slide, please. So we'll begin with our first poll question, which is in the 2014 Olympics in Sochi, Russia. As you can see, this is very relevant to dialysis and nephrology. Which team won the gold medal in women's hockey? And so we have U.S., Canada, Russia, or Sweden. So if you don't mind some audience participation, please submit your answer. Oh, I love it. So as you can see, 79% picked Canada as the winner of the women's gold medal in hockey, which is actually incorrect. It is the Americans who won the gold in 2014 in Sochi, Russia. And I think the DOPPS team is having some fun with me because they put that up there just to remind me of the rivalry we have in hockey, and that the U.S. women were able to steal away the gold medal from the Canadians. Thanks, DOPPS team. Next slide. Okay, so just looking at our healthcare system, so in Canada we have a universal healthcare which is funded by the government. It's completely non-profit, at least 99+%. Drugs are provided free for patients over the age of 65 with some minor costs there. Now, because of this universal access, we do have some limitations to primary care and specialist care in that there may be limitations on the number of primary care physicians, and some people find it difficult to find family physicians, and referrals for non-urgent specialist care can take a long time. As well, there are waiting lists for non-urgent procedures in Canada as well. The overall health spending is about $4,600 per person per annum. For dialysis patients, it's all public costs, and again, this is around $60,000 per patient. And the way the model is in Canada, regions, is often affiliated with university settings, are responsible for delivery of dialysis care. So you may have a region, for example, I'm in the Ottawa region, there's about a catchment area of 1.5 million, and the University of Ottawa's nephrology group is responsible for providing care for that entire region. No private dialysis clinic can come and open up in this area without an explicit discussion with us and our consent. And so there is a kind of a rationing of dialysis services in that way, or at least you could say it all goes through the responsible group for that region. Because of that, hospitals and other area healthcare facilities are given a flat cost for dialysis patients, but as we all know, dialysis patients have intensive needs. They end up in the emergency room, they require inpatient hospitalizations, and so in a way, dialysis patients are viewed as a source of cost to hospitals and healthcare facilities in Canada. Furthermore, it's organized by the provincial region, so by the provinces. And because of that, there's limited national coordination or standards that occur across provinces, and our data collection is also limited across the country. We contrast this with the American system, where we have the mix of both private and public health care, which is often by both private and public health insurance. Although dialysis patients are usually covered, there is a proportion of the population not on dialysis that has no coverage, and this could maybe impact access to care or preventative care. The overall health spending is higher in the U.S. At $9,400 per person, and you can, in some ways, it's not surprising why there are higher drug costs associated, but there's also a higher number of procedures and imaging modalities that are performed for the average dialysis patient, or for the average patient, in the U.S. Dialysis care is mostly under two large chains where a lot of amalgamation has occurred, and in some ways they unify care nationally by having sets of standards and operating procedures versus in Canada where it can be more disjointed. The average cost for a dialysis patient is $87,000 per year, and there was a drastic change in the landscape with the bundled reimbursement for dialysis patients in 2011, and I think that funding reimbursement changed the way a lot of things were being done, and maybe if there was any incentives to use injectables or whatnot, those things may have changed completely. And as opposed to the Canadian model, in the U.S., the patient is viewed perhaps as a source of revenue, in that the more patients you get, the more revenue you can make, and that's almost in a direct opposite of the Canadian view. Conversely, they have excellent data, and if maybe if Americans don't appreciate it, you have excellent CQI programs nationally and data collection.
Manish, one question from the audience. Is the comparison, or the numbers on this slide, in U.S. dollars or Canadian dollars?
This is both in U.S. dollars. So thank you for that question. Next slide. So this is a figure that was taken from a government report in Canada, but it's actually authored by an American group from the Commonwealth Fund. And what this does is looking at international healthcare comparisons across a lot of comparable countries. Canada is second from the left, and the U.S. is on the far right. And I don't think anybody is, in either of our countries, is going to be overtly excited looking at these numbers. The overall ranking for Canada out of 11 nations was 10th, and the U.S. was 11th. And if you look across the board, delivery of effective care, safe care, coordinated care, and patient-centered care was very low in Canada. The U.S. did moderately better, especially in effective care and patient-centered care. Cost-related access problems, better in Canada, but I think because there is a certain proportion of the population that lacks coverage, they were last in the U.S. And efficiency, equity, and healthy lives were ranked low. And you can see at the bottom the health expenditures per capita in 2011 are quoted along the bottom. So in some ways, by at least this metric or this measure, both our systems have yet a lot to learn. Next slide, please. So is home dialysis use higher in Canada or the U.S.? And our choice is Canada and the U.S. And if we could maybe go a little shorter on the music this time, please. Can we do the poll? So 76% said Canada. Next slide, please. As we go through the data, I'd like to show you the answer. Next is the incidence and or prevalence of ESKD higher in the U.S. or Canada? And here we have 97% are siding with the U.S. as higher incidence or prevalence, and this is a learned audience. Let's go on. Next slide, please. So here's a slide where if you look at the y-axis, it's the prevalence or chronic dialysis patients on ESKD, and then on the x-axis you have ESKD incidence or new cases. And what you could see is Canada's roughly about 150 new dialysis cases or ESKD cases per million. The U.S. is more than 2 times higher, in closer to 400. But then when you look at the prevalence, so these are kind of people who are living with the burden or chronic survivors, it's roughly 1,200 in Canada compared to roughly 2,000 in the U.S. So there's almost a 2.5-fold increase in the incidence, but not exactly a doubling of the prevalence. And I think that can speak to the survival in these two groups. But the U.S. has a much higher incidence and a higher prevalence, but not as greater degree for ESKD. Next slide, please. When we look at modality use among the countries, if you just look at the column on the right and the blue bars, just to orientate you, these are transplantation. And these are outstanding numbers when you look at countries like Norway, Iceland, Estonia. They have very high proportions of transplantation. If you go to the right column, we have both Canada and the U.S. And Canada does have higher proportion of ESKD patients who receive transplant. I think that's one of the things we can clearly see from the data. The second thing we can see is that there is more home dialysis use in general, and that's broken down by peritoneal dialysis and home hemodialysis are both combined about double of what they are in the U.S. Next slide, please. However, it's not all doom and gloom, I guess, with the U.S. Dialysis use picture. It has been increasing steadily. This slide is showing the percent of adult dialysis patients who have started home dialysis in the U.S., and we've seen a steady rise from about 8% to 10.7, almost 11% over the last few years. Is this perhaps financial incentives have been more favorable towards home dialysis therapies in the U.S., or is it a reflection of improved access and training in peritoneal dialysis? It's all speculative. But in Canada during the same time frame, for just an example, the numbers are roughly around 20% of the total ESKD population on home therapies. so roughly double. Next slide, please. So over time, if you're looking at outcomes, I think that the surprising, or not surprising, but encouraging thing is the dramatic drop in the death rate for U.S. ESKD population, hovering at roughly 0.25 per patient years, and it's down to almost 0.15, in line with the European countries. Canada is not explicitly on this, but Canada's been hovering around 0.15 to 0.16 throughout the last 1 or 2 decades. And you could speculate as the reasons why there's been this tremendous improvement in the U.S. There's been a lot of advancement in fistula use, achievement of targets, phosphorus control, and perhaps stabilization of hemoglobin levels to explain this. Next slide, please. So now we're going to go into some demographics of the ESKD population. Next. So on the left you have the U.S. and on the right you have Canada, and I'm just going to walk you through this. The kind of light blue bars are the what we say the white or Caucasian population. In the U.S. this is hovering around 60%. And the immediate thing you might notice is in Canada we're less maybe diverse. We have it's sitting around 70% for the ESKD population. And in the U.S., you have a large proportion who are identified as African American or Black, roughly 1/3. Where in Canada, this is a much smaller population, and instead we have a much larger population of groups that would be identified as Indigenous peoples or Aboriginals. Whereas in the U.S., this is a much smaller group. So you could just see, even just looking at this, that there's going to be differences just based on the racial demographic of the ESKD population. And if there are differences in, say, outcomes among these groups, that's going to contribute to some of the differences we might see overall. One idea or one way that possibly you could overcome this when you want to look at this is you could, for example, limit comparisons to, say, Caucasians only, but then it's not as generalizable, and at least that might be able to remove some of the racial variation. Next slide, please. Patient age, I think, is surprisingly similar across the two countries. This, on the left, is the U.S., on the right is Canada. It only goes back as far in this slide in April 2012. But really, over the last few decades, we've been seeing a large trend in the increase of the dialysis population over the age of 55. And Canada and the U.S. both have somewhat similar populations of elderly dialysis patients. Maybe Canada has slightly more patients who are over the age of 75. So maybe the truer geriatric population. Next slide, please. So this is the time on dialysis. And again, if you look at this comparison, the top blue bars are greater than 4 years, and the kind of orange bars are about 1 to 3.9 years. And both groups are roughly similar, with about 80% being on dialysis for greater than 1 year, and about 40% roughly greater than 4 years. Next slide, please. Diabetes is, as we know, a growing epidemic, I think, throughout both our countries, paralleled with obesity. The U.S. still does have slightly higher rates of diabetes when they start dialysis, and this may be geographic in the U.S. Canada does have a slight difference, up to maybe 5 to 10% lower percentage of diabetes at study entry. This could partially explain outcomes, but it also could be differ among the races.
Manish, there was a question from the audience related to our slide on death rate. Would uptake of palliative options contribute to the decreased noted death rate in the U.S. in particular? I think that the answer in the U.S., it is true that it's likely that the use of conservative kidney management has risen, although that's actually quite difficult to measure clearly. And these are patients who would develop kidney failure but end up not perhaps choosing not to start dialysis, particularly among older patients, and that likely is more common. I don't think that's a key driver of decreased mortality. I suspect that's still a relatively low proportion of patients who develop kidney failure. And indeed, we do see decreased mortality rates if, for example, we limit analyses to younger patients. We see comparable trend in decline. I don't know, Manish, if you have other comments on conservative management in Canada.
Yeah, that's a great point. Thank you for bringing that up. There is a growing trend in Canada to even have specialized streams and even or special clinics and whatnot towards full conservative care. It's tricky with our data collection because we do both the Canadian data system as well as I believe DOPPS captures patients once they start on dialysis. So the true incidence of ESRD encompassing those who do not go on dialysis and those who do is a little hazy and perhaps not known. But I agree with your point. So with that, can we continue to dialysis dose and prescription? And we have another poll question here of who has the longer dialysis treatment times, Canada or the U.S.? So again, from the polling numbers, it looks like the majority believe Canada does. Can we continue? And they are correct. Canada does have, I guess, on average, longer times. And what we have here is the U.S. On the left, Canada on the right again. And the times, so 3.5 hours is the blue bar, and between 3.5 to 4 is the yellow, and greater than 4 is the orange bars. And what you see, I guess, Canada is a much larger proportion, or a much smaller group, a much larger proportion over 3.5, or a much smaller group less than 3.5. Whereas the U.S. has at least 1/3 of their patients receiving 3.5 hours or less as their standard treatment time. And I think this is interesting. I don't know what this is driven by incentives. I'm not clear what the driver is. Is it patient preference? I think in Canada there has been a lot of trend towards longer dialysis, and there is a fair amount of home hemodialysis, and longer treatment times seem to be encouraged. And I wonder if that is going from the home hemo units and kind of being relayed to the intermittent units, where there's a general feeling that you should stay on longer for better outcomes. Next slide, please. So now we're going to go into mineral and bone disorders. Next. So first slide here is looking at serum PTH levels. And if you look, greater than 600 picograms per milliliter is hovering around roughly 20% in the U.S., maybe slightly higher in Canada, but the kind of mid-range PTH levels of 300 to 600 seem to be comparable between the two countries. And there does seem to be at least a slight higher proportion of patients who have low-range PTH levels in Canada. Next. So in what country, now we're going to go into therapeutics, is IV vitamin D prescribed to a higher percentage of patients? Is this, again, Canada or the U.S.? So the majority are saying the U.S., which is actually, yes, correct. Let's go to the next slide and look at the data, please. So this, I think, is one of the most interesting slides and really illustrates some of the differences between Canada and the U.S. when it comes to management. So if you look here, the U.S. is using very high proportions of IV vitamin D. and in the 90s, and then slowly, gradually decreasing down to the 60s and 70s. And from my understanding, this is some of the large dialysis providers have switched to oral, whereas Canada is almost exclusively oral for vitamin D. And as many people are aware, the evidence on this is not really there, that there's one superior to the other. I think it's unclear, and neither of them are related to differences in outcomes among the two. But I think here we really see a large difference. And I think in Canada, the major driver of this is cost. It's cheaper to use the oral vitamin D versus the IV formulation. Next slide, please. So one of the newer agents is cinacalcet. And I know there's been some recent evidence around this, large randomized controlled trials, but really, if you look at the uptake in the U.S. Of this drug, roughly, if not almost 1/3 of the dialysis population is using this medication, where in Canada, use is very low. And I know, at least from a few of the programs I've worked in and provincial programs, that they restrict the use of the drug related to often cost, and if a drug lacks a clear cost effectiveness and demonstration of efficacy, there seems to be a difficulty in getting it prescribed or getting it on our formularies in Canada in general. So that could be part of the driver behind why we see a disparity in the two groups. Next. Again, this is another dramatic slide showing the difference in phosphate binder used by countries. So the blue bars are calcium-based binder use exclusively, where if you look in the U.S., that's roughly 1/3, whereas in Canada, it's roughly 2/3. So 2/3 of our patients just take calcium binders, whereas Salvelamir or Renagel has made a significant inroads with the use in the U.S. population. There are another roughly 1/3, where Renagel use is low and probably falling in Canada. And some patients, the combination therapies are being used, but really Renagel is a small player in Canada. And the U.S. has seen the emergence of newer agents like these iron-containing agents and likely the other like lanthanum that are starting to develop some market share. Whereas in Canada, these are their iron binding have not really started to take a significant portion, at least as far as June 2015. Next. So now we'll look at anemia and iron. Which country has the highest achieved mean hemoglobin between Canada and the U.S.? And so it seems the majority of believe the U.S. Has the highest mean hemoglobin. Let's see. Next slide. So when we look at the breakdown of hemoglobins, in the U.S., you could see at least 90% roughly are going to be less than 120 or 11.9. So the reason I point that out is there's some concerns with the higher levels, greater than 120 or 12, being associated with thrombotic events. In Canada, we tend to have higher hemoglobins or more people in these higher ranges, greater than 12 or 120. There's a higher proportion there. And then when we look in the other extreme, the lowest proportion, people say under 9 or 90, both have relatively low populations in that group. So overall, if you do look at it, Canada does have a higher mean hemoglobin compared to the U.S. Next slide.
And Manish, actually, that's been an important change since the introduction, since the bundle payment system that was January of 2011, where the U.S. did have higher hemoglobin levels than elsewhere. Since then, they have they've now fallen below what we see in Canada, as well as in Europe. Actually, hemoglobin levels are clearly higher in Europe as well. And Canadian practice quite often is closer to what we see in Europe than in the U.S. Overall. Thank you.
Thank you. Great point. So IV iron use. So again, if we look in the U.S., there is in general more IV iron use, with 80+% of patients receiving it in the last 3 months, whereas in Canada that's at least about 10% lower, and perhaps trending down. There is some oral iron use in Canada, but I don't know if that could be one of the drivers behind this. Next slide. So another stark contrast comes in the mean or the distribution of serum ferritins between the two countries. So if you look in the U.S., there is a fair number, upwards to about 40% of patients who have a ferritin greater than 800. Whereas in Canada, that number would probably fall to the 15 to 20%. So roughly half of the number of patients who have high ferritins. And there have been these concerns, whether they've fully been proven or not, that high ferritins and administration of IV iron is linked to premature cardiovascular events. It is unclear whether this is truly causal, but I think in Canada people have steered a little clear of that number of 800 at least, and some centers have even tried to limit above the administration of IV iron with ferritins greater than 500. Next. So here's the median serum ferritin, and as you can see in the U.S., well over 500 and approaching 800, whereas in Canada, it's significantly lower, as I mentioned. And a lot of this has to do with, as I alluded to, there is concerns that there could be some adverse effects being given to the patients with IV iron with high ferritins at baseline. Next slide. So ESA use also differs significantly by the two countries. Canada, by and large, uses darbepoetin, and that appears to be the case for 2/3 of the majority, whereas the U.S. was almost 90+% dominated by EPO. And in the last few years, the introduction of pegylated EPO has started to take a considerable market share due to probably the ease of or simplified administration or dosing. But in Canada, that really hasn't entered the market yet. It could be here, but it hasn't really taken substantial market share. And I think you see this trend continually, where newer agents seem to be picked up in the U.S. earlier and develop market share and are being used, whereas in Canada there's a lag or agents may not be used at all. Next. ESA routes by country, again, mostly we're all receiving or delivering it by IV. Canada does have a higher amount of subcutaneous use of ESA, and I think this was mainly cost-driven, as the dosing is lower with the sub-Q administration, so there can be a cost savings if you deliver it that route. But again, individual regions have negotiated, for example, deals with the pharmaceutical companies where they've given them equivalent dosing, so cost doesn't always bear an effect, but it depends region to region.
Sorry, Manish, there was one question. Could the difference in ferritin be explained by the difference in ESA dose in Canada versus the U.S.? But we had, just to note, we had published in CJASN about a year ago that part of the rise in ferritin in the U.S. is explained by reduction in ESA dose. So therefore, if roughly the same amount of iron were given, but lower ESA doses are given, that will tend to drive up ferritin as iron moved preferentially into stores as opposed to into erythropoiesis. I think ultimately this doesn't explain the differences in ferritin. And actually doses between the two countries are now going to be pretty comparable. Weight-adjusted doses will be pretty comparable. I think principally we're simply seeing iron dosing to different targets in the U.S. compared to Canada, where in the U.S. it's very common to have an upper ferritin target of 1,200 in many sites, whereas to my understanding, an upper targets max out at about 800 in Canada.
I think that's a great point, and you're correct. I have not heard of a center in Canada with a max target of 1,200 for ferritin. So maybe the caution is unfounded, maybe it is, but this seems to be the practice pattern north of the border. And as the EPREX dosing, also, I know we were at one point, this may have changed in the last few years since the bundling, but Canada was using fairly lower doses, and we capped our doses for recombinant erythropoietin. Often as cost measure, we wouldn't give patients who we felt were EPO resistant any higher levels of EPO, and it wasn't a measured target, for example. Great question. So last slide. Last, we're going to discuss vascular access. Next, please. And this, I think, many nephrologists in Canada think of this as a point of shame for our country, in that Canada is just ubiquitous with catheters almost. We have almost a 50% catheter rate for our patient population. We have almost nil grafts and a less than 50% fistula rate. And I know the U.S. has been such a success story with the Fistula First initiative, and even though many Canadians were involved with it and we were seeing it, for some reason the uptake or the movement didn't seem to happen here, where the U.S. fistula rates are terrific. 2/3 are having fistulas, and then if you add on grafts, really catheter use is approaching, maybe one day can be in the single digits, would be a phenomenal accomplishment. But that being said, there's been a lot of speculation as to why Canada has such high catheter rates. Some previous DOPPS studies done by David Mendelsohn looked at things like access to vascular surgeons, wait times, times of imaging to get worked up, and the vessel mapping prior. And all of those things were much longer in Canada compared to other DOPPS nations. And is this a driver? It is possible. Next slide, please. And then here is patients when they start. Those were prevalent dialysis patients. These are new start dialysis patients, and this, in a way, makes the situation look even worse because U.S. and Canada essentially are starting patients with 2/3 catheters, and the U.S. is successfully able to convert them then to get a fistula or a graft. So we're starting from the same point, but really Canada is not able to convert these catheters to fistulas at any reasonable level. And this has been going on for about 15 years plus in Canada, and it really hasn't, we haven't been able to make large measurable differences in our fistula rate. Next. So I went a little bit over time. I hope that's okay, but just to summarize some of my thoughts on the comparisons of the two, we're such geographically close neighbors, yet we're so different in many of the ways we practice with our populations with respect to dialysis. We have huge demographic and racial differences. We have higher incidence and prevalence in the U.S. of dialysis compared to Canada. Some broad conclusions are that it appears, if I'm creating an editorial comment here, that Canadian dialysis patients or programs seem more cost conscious. We need to see things be cost effective or proven by evidence before they start entering the system, whereas the U.S. I would say is more innovative, at least when it comes to therapeutics and medications. They're much more likely to start taking on new medications and trying them out. The U.S. has more fistula, shorter treatment time, uses Renagel, has higher mean ferritins, and we're seeing a steady increase in these newer ESA agents. Whereas in Canada, we have more home dialysis, longer treatment times, and burdened with a tremendously high catheter rate. Meanwhile, we seem to like our calcium binders, and we have a slightly higher use of sub-Q ESA, and we use mainly darbepoetin. I hope that this exercise was illustrative for people who are interested in comparisons between countries, and I think it was a nice example of how the Dialysis Practice Monitor can be used to provide valuable information between countries. One caveat that I made an error that I have to correct myself on, otherwise I will be thrown out of this country. Canada did win the women's Olympic gold in Sochi in overtime. I apologize to the Canadian women Olympic hockey team, but we did win that one. Anyway, thank you.
Manish, thank you so much for that really great overview and for input from the audience along the way. Really appreciate that. In the interest of time, we'll move on quickly to a brief update on payment and policy related to the ESRD program for 2017. Mark Newman, who leads Nephrology News and Issues and co-hosts this web conference with us, will give this update. Mark.
Thanks, Bruce, and thanks as always for inviting me to this WebEx. It's a great opportunity for us. I wanted to talk about a couple of things that we mentioned the last WebEx, just to give everybody a quick update, and then we'll go into some new information and some ongoing developments. So the first thing that was passed in January that was very important, that everybody was looking forward to in terms of getting passage through Congress, was getting AKI care in the freestanding clinic. This now allows patients to be treated in an outpatient facility. A reimbursement is really for unlimited treatments, although as you'll see at the bottom of the slide, we certainly talk about CMS will be watching. But ultimately, what they're saying is these patients are special. They need treatments more than 3 times a week. We'll pay for that, and that's an important message. Some services will also be billed outside the composite rate because, again, these patients need more tests, more lab tests, more intensive care. CMS is recognizing that. And also they're going to be you will be allowed to do PD, but it will have to be done in center, and it will have to be approved. This will not be a home therapy. But nonetheless, it was an important step forward for the renal community. They've been working on this for quite some time. And there are certainly a number of patients that already have been using this benefit. And everybody's sort of watching about what it will do to staff-patient ratios and workload and expertise. So nonetheless, it is on the books. Next slide. Medicare Advantage plans, this was also approved in January. It basically no longer discriminates against ESRD patients who want to join Medicare Advantage plans. Previously, it was only allowed if you were already in a plan and you developed ESRD. Now there's really no restrictions, and that was also a major push by the renal community. Next slide. ESCOs, they've been going on, this project has been going on for over a year, almost closing in on 2 years now. This was launched in 2015, excuse me. But CMS was concerned that the only participants were large providers. So they reopened up the application process. They approved 24 new ESCOs. So now we have 37 sites in operation. The link there is to a story on our website that gives you the details of all the participants and the players. You can simply go to the website and punch in ESCO and you'll get the same thing. But the link provides all names of all the players and also where they're located. So it's a really good, handy chart. But you can see at the bottom, these are the participants that are part of the program. Now, Fresenius obviously has the lion's share of these. They're very confident about the ESCO model, and they want to move forward with it. DaVita is still only at 3 where they started originally. DCI picked up 3 more, so they're at 6. And here are the new players. Northwest Kidney, Rogerson was already part of the original plan, Atlantic Dialysis Services, and Centers for Dialysis Care. So those are 3 new players. but obviously Fresenius has the lion's share of these. Next slide. Nothing really new yet on 5-star ratings. This gets a refresh every year. I just thought I'd throw this slide in here as well, so we expect to see something in October. Next slide. But what you can see from this chart is what occurred in the last refresh, and I shared this in the January WebEx as well. In essence, the renal committee was complaining that because of a bell-shaped curve approach to this, there was a cap on the number of clinics that could be 5-star, 4-star, 3-star, etc. They've sort of removed that curve approach, and now they're looking at it from a different criteria and looking at clinics in a different way. And so what we have now is a growth in the number of 5-stars. You can see by the chart on the right where it shows what happened with the last refresh. A significant increase in 5-star clinics, 4-star clinics. 3-star came down a little bit, 2-star, etc. So it's a redistribution, but the point from the renal community is that there are many clinics that deserve these higher ratings. And that's in essence what the refresh did. So we may see this change even more in October when they do a refresh. Next slide. Okay, so here's some new policies that are either being developed. Most of these are in development in terms of being in Congress. This one we're going to talk about in a second is a state law which has gotten a lot of attention, not just in NNI but also in the general media, and that is the Dialysis Patient Safety Act. This is new legislation being proposed in California, specifically Senate Bill 349 would impose mandatory staffing ratios for dialysis clinics in California. You can see what those ratios would be. There would also be a required 45 minutes between shifts in terms of getting patients off and putting new patients on. And then they would do all this packaged into a state licensure program where you would have yearly inspections. Next slide. So there's been a lot of controversy about this. Mainly, as you might expect, providers are against it. They're concerned about mandatory ratios. They're concerned about finding enough nurses. And there's some severe penalties in this, unlike other states where there are ratios in place. This particular one has a number of serious penalties if you do not meet the ratios, and that is a major concern, particularly since, as I mentioned, providers are worried about finding enough nurses to fill the requirements. It could be something as simple as a nurse calling in sick or a technician calling in sick or some other issue, and you suddenly find yourself not meeting that ratio. Do you shut down the clinic? Do you send patients to the ER? That's what providers are talking about. This particular bill also is backed by a union in California, which is very strong in the hospital arena in that state, and they are now trying to organize dialysis nurses. So there is let's just say there is a motivation by the union to see this bill passed. It has already passed 2 Senate committees and is now facing the Appropriations Committee this month. As I mentioned, providers are against it. Some renal associations have expressed concern, and some patient groups as well, by the way, which is kind of interesting that you would figure all patients would be for this. But there is a concern about the ratios, and also the 45 minutes between shifts might in fact delay some later shifts that are now available for working patients. Some of the renal associations are concerned because they don't see any major evidence that it's been already shown in other states where there are ratios that this in fact has improved quality. Some of the arguments against it have also indicated that in California, and again, if we follow the 5-star ratings and we believe they have value, that there are more 4- and 5-star clinics in California than other states, and particularly more so than in states that have staffing ratios. So it's a question of are we fixing a problem that's not really there, and that's the provider's argument. The next hearing will be later this month. We'll see where it goes, and then obviously it'll need to be voted on by the full Senate. Next slide. The Chronic Care Act is a Senate Bill 870. This is in Congress. This really fixes something that should have been done the first time. and that is that it addresses telehealth issues for home dialysis patients, and that in the original bill, it didn't allow the home to be, in essence, a service area for telehealth, which doesn't make a lot of sense. So this is really almost like a clerical correction, but one that's needed in order to make telehealth work. So that would change beginning in 2019. Next slide. The Living Donor Protection Act, this is also a House bill, excuse me, and this would prohibit insurance companies from denying or limiting coverage and from charging higher premiums for patients who have donated. It also clarifies that living organ donors may use Family and Medical Leave Act time to recover, and it also directs Health and Human Services to encourage more individuals to donate. I think this is a great quote from the CEO from National Kidney Foundation. It's unfortunate that even today we still see our nation's living donors being denied insurance or having their premiums increase because they made a selfless decision to donate an organ to someone in need. I think it really capsulizes what the issues are. We need to respect those individuals who agree to donate. We need to make it easy for them, and we certainly don't want to put any barriers or penalties in their way in terms of lost wages and the inability to get insurance because they did something of goodwill. And I think that's really the purpose of that this particular legislation. Next slide. Here's some other brief news that's been occurring, not necessarily as important or strong headlines, but many of you have remembered the situation with dialysis providers and third-party payers. A lot of controversy last year about concerns that dialysis providers were steering patients into private insurance plans through the ACA, and they were doing this in essence to be able to charge payers more money for dialysis. The CMS tried to pass a final rule on this. It was struck down by the courts because the sense was that it was a last-minute ditch effort by the Obama administration, and so that was null and void in essence. So nothing has really changed in that regard, but there are still health plans who are coming out and saying they do not want to accept third-party payments from the American Kidney Fund to cover premiums. And technically, CMS language allows them to turn down patients if, in fact, the premiums are coming from a third-party payer. Providers are fighting this. In some cases, they're trying to disguise how the money is getting to the insurers. The insurers don't like that, so this is still messy, and there really hasn't been anything figured out in how to resolve this. And of course, the AKF has been caught in the middle of this as well. So this is an ongoing issue with no real clarity on when it might fix itself, in essence. DaVita finalized acquisition of Renal Ventures Management. This has been a long-term project for them, and they also had to divest 7 clinics because of concerns about antitrust. They also just acquired a small group in Wisconsin. We have next month in July our annual dialysis provider survey, which many of you are familiar with. And in that case, in that survey, we rank the 10 largest dialysis providers based on patient count. And my guess is, based on the RVM acquisition and this Wisconsin group, that DaVita will, for the first time in the 20 years we've done this survey, will in fact be number 1 in terms of patient count. So that will be historic in that respect. We'll talk about DaVita in a minute after my last slide. And then lastly, Baxter is developing a new PD solution generation system that would produce sterile PD solutions in patients' homes. This seems like the next wave of technology in terms of dealing with PD. We know NextStage is working on its own PD machine that would, in essence, do very much the same thing, eliminate the bags in terms of having to bring bags in as supplies and being able to produce the solution on site. And obviously, Baxter, knowing the problems they had a couple of years ago with dialysate shortage, they may be looking at this as a way to eliminate that concern as well. So both those companies are working on new technologies. Fresenius is also working on a new PD machine. So I'm guessing in the next couple of years, we're going to see some new advances in technology for PD. Next slide. And my last one. If you have not heard about this segment of the John Oliver Show, you probably should look at it. This came out just a few days ago. John Oliver is a talk show host, and he focused the whole 27 minutes of this segment on dialysis. It's a parody. People can be offended by it. Some people might find it funny, but he makes a lot of fun of the way Ken Theory runs his company at DaVita, and he looks at some of our outcomes data and basically says we're spending a lot of money on this program, and he's not sure exactly if the taxpayers are getting the value. So look it up, give it a look. I think at the minimum you should do that. It's already gotten thousands of hits on Facebook and on Google, and DaVita has responded to this in a very straightforward way. We're not going to change our culture. This is who we are. There's also been some push on this by the union, ironically, who's also looking to pass those staff-patient ratios in California. So there's some suggestion that they were perhaps helping John Oliver with the research on this. But nonetheless, whether you like it or hate it, it's a good idea to give it a look. It's accessible via YouTube, and it's of interest. If you're in this community, you should take a look at it. Next slide. We had asked about a couple of questions. I don't know if we have time to do this, Bruce, or not.
I thought, yeah, Mark, if anything, you may just get a poll response to this particular poll question, and then we'll call an end to things because of the time.
Okay, that sounds
fine. We can do just this one.
So, and I think this is, of course, determined by those who have seen it. But if you have seen it and you have some reaction to it, we'd like to hear about it. So if you would submit a response to this question, we'll post the results.
Okay, Mark, results are here. Yeah.
Yes, indeed. So it looks like a lot of folks have not seen it. Those who have, are acknowledging that there are some issues that John Oliver presents. I think that's interesting. So if you haven't seen it yet, certainly give it a look. As I mentioned earlier, I think it covers our industry, and it's something that you should be aware of.
Okay, Mark, thank you so much. Yeah, Mark, great update. Thanks. And as always, there's so much going on, and we really appreciate your quick overview. And to Dr. Sood at University of Ottawa, thank you again for your presentation, and thanks to those of you who called in and participated in the web conference today. Our next update to the DOPPS Practice Monitor is in August, and we'll follow that in September with a web conference as well. And until then, thanks very much. Have a good afternoon. Bye-bye.